All right, jumping right into some acyanotic defects, we're going to begin with defects that increase pulmonary blood flow. So this category has 3 defects: a PDA, which is basically a trapdoor that doesn't close, and then septal defects, either ventricular or atrial. Now, all will present with murmurs since blood is moving to places it shouldn't be whooshing its way from high pressure to low pressure. And you're also going to see signs and symptoms of heart failure since increased blood flow to the lungs increases the pulmonary blood pressure and stresses the heart, because the heart just wants to do its job, right? It doesn't want to be extra. So a ventricular septal defect will show up in the first week or 2 of life with a murmur due to the changes in that neonatal circulation, and the size can vary. The left to right shunt is there because of the increased pulmonary blood flow, and so that blood from the left ventricle is pushed through the hole into the right ventricle, and that is resulting in increased flow to the lungs. Now, an atrial septal defect is up between the 2 atria, and again, this becomes evident in that first week or 2 of life. The size also does vary. Just keep in mind that this is larger than a PFO or a patent foramen ovale, although a PFO is also considered a form of atrial septal defect. An actual ASD, when categorized, is larger. So you will have a left to right shunt here, and you have increased pulmonary blood flow because the blood from the left atria is pushed through the hole into the right atria. See a pattern here? This could cause pulmonary hypertension as well as a decreased cerebral blood flow if it's more severe. Some signs and symptoms of these septal defects include the following. We have poor eating and failure to thrive because they're exhausted. You'll hear a murmur. There might be some tachypnea or breathlessness, easy tiring, which ties into that poor eating and failure to thrive, but they could also be asymptomatic if it's mild. So what do we do with them? Well, small defects can close on their own, or they just might require observation. The heart is a very good organ when it comes to compensation, and so a lot of these defects just go unnoticed or undiagnosed. For unrepaired small defects, if we know that they are there, they can be prone to bacterial endocarditis because tissue can collect around those defects since there's been damage or a lack of structure. And so those kids do need pre-procedure antibiotic prophylaxis for surgeries and for dental procedures. And then for larger defects, we'll be looking at either treating and preventing the symptoms of CHF with medications, or we can patch it. And we would do that via a cardiac catheterization. A PDA is a channel between the pulmonary artery and the aorta, as seen in this photo, dumping blood back toward the lungs instead of out to the body. Now, in certain cases, a PDA is actually useful because it can be the only adequate source of blood flow to the lungs. In cases of pulmonary atresia or stenosis, transposition up the great arteries, and tetralogy of Fallot, we want the PDA to stay open until we can repair the underlying issue because it's the only place that the blood can get through. And so we would use prostaglandins for that. Repair is generally through ligation, where stitches or clips will close the opening, or you can use a coil, though there is a risk of embolism if that coil detaches and decides to take a trip. Larger PDAs will be ligated for that reason. Okay, now let's move on to obstructive defects. So these are acyanotic as well, and there's 2 main ones I'd like to talk about: coarctation of the aorta and aortic stenosis. And these are both pretty similar, just the location shifts a bit. In aortic stenosis, the aortic valve is narrowed, and in coarctation, it's the descending aorta that is narrowed. So this is an important location difference. Coarctation is past the subclavian, brachial, and carotid arteries. So your upper body blood pressures will be normal, while the lower body blood pressures are going to be low. And you don't see this in aortic stenosis, however, because the obstruction is below all the arteries. So you'll end up with that left ventricle working overtime, and this can lead to enlargement of that ventricle as well as left-sided heart failure. Aortic stenosis repair requires a valve replacement. Coarctation can be repaired by either a resection, where they will remove that narrowed section and then reconnect the edge, or they can do a balloon angioplasty to widen the diameter of the blood vessel. Tetralogy of Fallot may be one of the more well-known terms in cardiology. So when we talk about these cyanotic defects that result in decreased pulmonary blood flow, we're going to focus on that. Tricuspid atresia is where the tricuspid valve is missing or abnormally developed. And so in order for either of these conditions to be survivable, these kids need a PFO until that opening can be created for them. There is usually a VSD as well, and this allows the blood from the right atrium to move into the left and to mix with oxygenated blood. Tetralogy of Fallot is the name for 4 abnormalities of the heart that occur at once, hence tetralogy. You can use the mnemonic PROVE. It would include pulmonary stenosis, where the pulmonic valve is narrowed, right ventricular hypertrophy, where the muscle thickens, overriding aorta, which partially covers an existing ventricular septal defect rather than being over the left ventricle. Messy, right? And yet it's the most common cyanotic heart defect. So kids with tetralogy of Fallot are often called blue babies because when they get mad, they turn blue or purple. And it's not really super important to know all the specific defects. I don't know how often you get questioned about it on NCLEX, but the effects of the defect are what is very important. So one of the cardinal symptoms of tetralogy of Fallot are these TET spells, and these are hypercyanotic conditions that occur when a kid gets mad. So when they start to bear down, when they get agitated, what this ends up doing is resulting in an inability of the blood to get back into the lungs to get oxygenated. And so these kids will basically just start changing colors. And the sort of standby intervention for it is to put their knees to their chest, to give them oxygen, and sometimes even to use morphine in order to calm them down so that they can change that pressure gradient and allow the blood flow to start occurring more normally. Older children will compensate by squatting down to get their knees to their chest so that they can get the oxygen that they need. So chronic hypoxemia, which can occur in heart defects, can cause secondary polycythemia, which will increase hematocrit levels because your oxygen is low and the body is compensating by trying to make more oxygen-carrying cells. So this can be mitigated by oxygen support and adequate hydration. And a way that I kind of remember this is if you're familiar at all with extreme mountaineers and people who do a lot of hiking in high altitude areas, they tend to also have polycythemia because their body is trying to create more red blood cells so that they can transport more oxygen to compensate for that hypoxemic state that the environment that they're hiking in is creating. So we also want to minimize energy expenditure in these kids. They can use that oxygen for their primary functions instead of all of the other things. So we want to keep them calm and then watch for signs and symptoms of infection, especially respiratory. So looking at these TET spells, these are some pictures of those knee to chest positions I mentioned. You have this parent holding a child here. Honestly, you'd probably want them even farther up than that. And then a photo of what it would look like in an older child or even an adult based on this Adidas meme that they have here. Okay. So we do have surgical repairs for tetralogy of Fallot. They usually do a complete repair by 6 months of age. A surgical palliative procedure can be done at first, and this is called an MBTT shunt. And this is now a modified shunt, which is what the M is for, and I'll go into that in a minute. But it is a shunt that is made of Gore-Tex, and it connects a branch of the aorta to a pulmonary artery to help bypass so that they can continue to get oxygen. So it is called a Blalock-Taussig shunt, and it's actually a Blalock-Thomas-Taussig shunt. And there is a historical reason why we are now calling it BTT instead of BT, and we're going to talk about that in class for a little bit. But what this does is it allows more blood flow into the lung. Initially, the shunt was actually not synthetic. They were using the artery to connect it, and then they modified it to make it a synthetic procedure. So now we are MBTT. And this means that it doesn't grow with the child. So it's a temporary solution that just buys them some time to do a more permanent repair. There are some risks here that the shunt might close off or they could develop thrombosis. And so these infants are placed on aspirin as a mild anticoagulant. So now on to mixed defects. You could have transposition of the great arteries, truncus arteriosus, and hypoplastic left heart syndrome. Signs and symptoms of these defects would be varying degrees of hypoxemia and signs and symptoms of heart failure. I feel like there's a trend here at this point. You notice a trend? Transposition of the great arteries is kind of what it sounds like. It's where the arteries are swapped, and it's diagnosed as a newborn. Cyanosis is not improved by oxygen in this case. An echo will show the abnormal connections, and there needs to be immediate management done to treat this condition. So they need someplace in that circulation that the blood can mix. So these kiddos are going to need an ASD, and they're going to need to keep that PDA open. We're still going to see very low oxygen saturations in these kids, 75 to 85%, because they're just not oxygenating their blood properly. So the way they treat it is they do an arterial switch. And they actually just take both of those arteries and they flip their location so that they're actually headed into the correct plumbing that they need to be in to do their jobs. So that would be a pretty hefty procedure, if you can imagine. Moving on, I know that seems like I didn't give that enough space, but it really, honestly, that's kind of it. It's a big open heart procedure, and then we have recovery. Hypoplastic left heart, here is a picture of it. You can see how that left heart almost has no ventricle at all and almost no atria because the muscle and tissue is just so overdeveloped. And as you can imagine, that really decreases the volume that can be utilized and how much you can actually pump that blood out of the heart and into the systemic circulation. So we would see heart failure. So we're going to talk briefly about congestive heart failure because all these physiologies lead to the same finish line, right? Treatment is going to depend on the stage of heart failure that they are in, and we use those treatments based on adult studies because there's just a lower incidence of CHF in pediatrics. So what are some signs of CHF? Well, a lot of these we've gone over with all the heart defects because they all have some level of heart failure associated with them. We see poor feeding, activity intolerance, essentially, which then leads to poor weight gain. They also have increased metabolic needs, and so these things just kind of work in tandem to create this really messy situation where they're not gaining weight. They'll have a rapid respiratory rate with dyspnea and retractions. They could have a cough or wheezing because of the edema of the bronchial mucosa. They're going to sweat during exertion. They will also have tachycardia due to their sympathetic nervous system, and we might see some decreased urine output as well. So how are we going to treat it? Well, medical therapy, right? We want to reduce preload by giving diuretics like Lasix. We want to reduce afterload by giving some ACE inhibitors or beta blockers. And then we want to improve the contractility of their heart with digoxin. And essentially, at the base of everything is we need to correct the underlying problem and get in there and fix that defect. So digoxin in kids, it increases your cardiac output. It decreases the heart size. It decreases your venous pressure, all of those things. And as a nurse, there are some very specific things we need to think about with digoxin, and this should overlap with adult pharmacology, so it should sound familiar. We want to monitor for side effects, especially dysrhythmias. And patients will often have a baseline EKG when starting a medication or with dose changes, which will happen pretty frequently in children because kids are growing really rapidly, and we need to maintain that therapeutic dose. We're also teaching the parents about administration rules, about checking accurate apical heart rates before doses. Okay, so we got to show them how to do that. And then for signs and symptoms of toxicity, such as nausea and vomiting, anorexia, bradycardia, and dysrhythmia. This is also a medication that we do not re-administer if the patient vomits after taking it because we don't know how much they have gotten, and that range of therapeutic levels is so narrow that we just cannot risk giving them more, okay? For nursing care of the cardiac kid, we want to administer those drugs on schedule. We want to assess for side effects and symptoms of dig toxicity, as I mentioned. We also want to cluster care and allow for interrupted sleep and make sure that they are getting rest. 3-hour feeding schedules work really well for these infants, and we want to use soft nipples just to decrease energy. We want to hold them upright. Everything that we can do to make it easier, because eating for an infant is actually a really, really hard activity. They burn a lot of calories doing it. So we're going to limit those feedings to 20 to 30 minutes. And if they do still need more rest, we will switch to NG feedings. And then there's also other options like fortifying the breast milk or the formula so that they can actually get more calories per feeding. So we obviously want to use simple phrases when giving medication education to parents and just in general. Cardiac is hard. So we want to tell them things like digoxin will strengthen the heart so it can pump more efficiently. The ACE inhibitors are going to dilate the blood vessels so it's easier for the heart to work, right? This is not for hypertension, and we want to make sure that they know that. Diuretics are going to help the kidneys remove fluid from the lungs and the body because they're not doing it because their feet are swollen, right? Like you'd see in an older adult. It's because the heart and the lungs are working really hard since there's so much fluid building up in there. So in summary, make sure that you understand those hemodynamic effects, more important than actually memorizing each individual one. Understand the signs and symptoms of CHF and hypoxemia in the infant and child, and understand how we're going to be educating the family and what we're going to be doing as nurses at the bedside. All right, have a great day, everybody.